Yeah, are you guys able to see that?
Yeah.
We can see it.
Yeah, cool. Alrighty. So we'll make a start. It'll be a pretty brief overview, as I said, of some pretty common upper GI topics. And I want you guys to kind of get as interactive as possible. This isn't a formal session, it's pretty casual. Ask questions as we go along. And I'll round it off with a bit of a common OSCE scenario that you guys can kind of together and tackle and ask questions. Yeah, so this is an overview of the topics we'll cover. So starting with reflux or GORD, some reflux to some degree is physiological, and that's typically, brief post meals and asymptomatic. But when you get to a point where it causes troublesome symptoms or complications, and it's considered pathological. GORD roughly has a prevalence somewhere between 10 to 20%, so it's fairly common. Risk factor wise, there's a genetic and inherited component. Small contribution by increasing age. Pregnancy also increases the risk. Anyone think of why?
Increase intra-abdominal pressure.
Yeah, exactly. Increase of intra-abdominal pressure and reflux. Lifestyle, dietary, so the classic risk factors are smoking, alcohol, obesity for similar reasons to pregnancy. It's got a bit of an association with some medical comorbidities, and then obviously you've got mechanical or physiological esophageal disorders that can predispose to it. So this is a bit of a busy slide, but I think it gives a pretty good overview of how you can kind of break up in your mind the classic symptoms of GORD, as well as some of the complications and syndromes. And it's pretty handy in your mind, especially if you're kind of heading into an OSCE situation, to break things up as kind of esophageal related and extra esophageal related, because then that'll help you make sure that you tick off all the relevant questions. The classic presentation is heartburn, so typically a retrosternal burning sensation, typically postprandial, as well as a component of volume regurgitation. Other kind of more non-specific symptoms can include dysphagia, water pressure, that's kind of like excessive salivation, a bit of a Glover sensation and nausea. Here you can see some of the typical complications listed that we will touch on a bit later, but it's important not to overlook the extraintestinal manifestations. So cough, laryngitis, it can also lead to asthma and obviously dental erosions as well. So important to screen for those symptoms in a reflux patient. In terms of the diagnosis, you can generally base it on the classic symptoms of heartburn and regurgitation, and some will also use a response or a positive response to PPI therapy as being an indicator for reflux. And you can further investigate within an endoscopy. The diagnosis isn't clear if they have any red flag symptoms, which we'll touch on in a moment, or if they have multiple risk factors for Barrett's. If you suspect they have GORD based on their clinical history, however, the endoscopy is macroscopically unremarkable, you can consider a manometry study to rule out an underlying motility disorder. So here are those kind of classic red flag symptoms that warrant an endoscopy. And once again, in a history, in taking a history in a patient with reflux, you should be asking about all of these red flags as well. So new onset symptoms in an older person obviously is a concerning finding. If they've got any symptoms, I would suggest they have an upper GI bleed. So that's hematemesis melena or a finding of an iron deficiency anemia, you should further investigate. Any constitutional symptoms, dysphagia or dynaphagia, any persistent vomiting, or if they've got a pretty strong family history of cancer. In terms of risk factors for Barrett's, you probably should do an endoscopy or consider an endoscopy in a patient with long-standing GORD combined with one of these factors that are listed. Then you can read that for yourselves. And, you know, they're obviously all risk factors that be synonymous with increasing your chance of Barrett's and subsequent cancer. So coming to endoscopy, as I touched on before, they may have no visible findings. On the other hand, you might find overt esophagitis, you might have ulcerations, or similarly, you might find complications of reflux, so strictures or evidence of Barrett's, or, you know, a great big cancer, as you can see there on the far right image. These patients should have a biopsy done. And why might you be keen on doing a biopsy? So anyone just shout an answer?
Check for any dysplasia.
Yeah, correct. So any dysplasia underlying Barrett's, and also you can kind of see histological features of gastritis as well. There are various classification systems as well that can be used to categorize the severity of esophagitis, and the LA criteria is kind of a classic one that's typically used. Coming to the management of GORD, it's good if you're giving an answer in an OSCE station or an exam in general to break up your management into kind of non-pharmacological and pharmacological management. So your non-pharmacological kind of pins on lifestyle and dietary changes. So obviously things like weight loss and sleeping with the head of the bed raised, particularly if they've got nocturnal symptoms. Eliminating any food triggers and listing here some of the common culprits, and they should obviously stop smoking and alcohol intake. Other things include kind of avoiding heavy meals close to bedtime. In terms of medications, guidelines that you look at will kind of offer histamine receptor antagonists and PPIs as both being reasonable options. In SA, PPIs such as pantoprazole, esomeprazole tend to be the go-to first line. So that can be started, and you should reassess their response after a 4 to 8 week trial of that. And if they've got pretty mild symptoms and that PPI gets on top of things pretty well, then you can aim to gradually taper them off that PPI and only use it as an on-need basis. Obviously, if they end up having an endoscopy and there's any inkling of complicated disease or more severe reflux, then they should be on a PPI long term. The aim there to kind of minimise PPI use kind of in patients with pretty minimal symptoms is obviously to minimise pill burden and PPIs. Whilst the risks are small, they aren't without complications and side effects. Obviously, being an upper GI surgical talk, I'll briefly touch on some of the indications for surgery. So these are the main ones that you guys should have in mind. So if they've got severe symptoms that are incompletely controlled by best medical therapy and optimizing their lifestyle, if for some reason they're intolerant of medical therapy or they're non-compliant or not wishing to pursue lifelong medical therapy, then surgery could be explored. Similarly, if they've got troublesome kind of extra GI symptoms, along with objective evidence that has reflux as a culprit of those manifestations, then reflux surgery can be considered. In terms of teeing up someone for an operation, the pre-op workup includes an endoscopy if it hadn't already been done earlier on in the piece. They should have esophageal pH testing and manometry studies done. Can you think why manometry studies would be relevant? Does anyone want to have a go at this answer? It's probably a bit more of a tricky question. What was that, sorry?
Could achalasia be a differential? Yeah,
exactly. And I'll be touching on one of the more common operations that's done in the moment, which is a fundoplication. But obviously, if someone has an esophageal dysmotility disorder, where their sphincter function isn't working or it's hyperspastic, then going and wrapping the fundus around the distal esophagus is obviously a bad idea. So you need to have a good idea of how their esophagus is functioning. And a barium swallow, why might that be pertinent?
Strictures or cancers?
Yeah, so you might pick up on an obvious intraluminal filling defect suggestive of cancer. I mean, if they've had an endoscopy, that'll pick up on it anyway. Barium swallow will also give you a clue towards whether they have a motility disorder. But another thing that it's pretty good at picking up is if they have a hiatus hernia. So that's going to have some influence on operative management. So you'd obviously include a hiatus hernia repair as part of a fundoplication. So that's why that's useful. And as I've got on the bottom of the slide there, it's a fairly highly specialized decision, taking into account patient and disease characteristics and exactly what operation an upper GI surgeon is going to go with. Just so you guys have a broad overview on a common operation that's done, and in case it comes up in an MCQ, it's good to have an awareness of what this surgery involves and some of the classic possible complications. So a Nissen fundoplication, as you can see in the diagram here, involves mobilizing the fundus of the stomach and wrapping that essentially around the distal esophagus. Basically, you're bolstering the function of the distal esophageal sphincter and aiming to minimize reflux. There are various approaches. It's typically done laparoscopically, and a whole variety of extent, so 360, 270, 180, and so on, fundoplication. That's all kind of tailored to the patient's symptoms and disease characteristics. Patients, very importantly, need to be counseled on the risk of dysphagia post-fundoplication. Gas bloat syndrome is quite a significant possible complication from a quality of life point of view. So that's basically where they're full and bloated after meals and they can't belch. It can be obviously very distressing. They should be counselled and warned about that. They can have other GI symptoms relating to damage to the vagus nerve. So obviously, you guys would recall, you can see it on the diagram here, that the vagal trunks kind of run anterior and posteriorly at that part of the esophagus. So it's easy for them to be injured, obviously, and that can lead to delayed gastric emptying. When those sutures are thrown there to tack the wrap, there's obviously a risk of, and also when you're mobilizing the stomach, there's a risk of causing a distal esophageal perforation, and that can lead to intra-abdominal sepsis or mediastinitis, which can be quite severe and life-threatening. Cool, so we'll move on to Barrett's esophagus now. So as you'd recall from pre-clin days, it's basically a metaplastic replacement of your classic stratified squamous epithelium that typically lines the distal esophagus with the intestinal columnar epithelium from the stomach, and that's obviously the body's response to chronic acid exposure and reflux in the distal esophagus. Barrett's confers roughly a 30 times increase in esophageal cancer relative to the general population. It's roughly 2 to 3 times more common in men. It's typically diagnosed in middle to older age. A lot of the risk factors overlap with malignancy. So obviously reflux, central obesity, family history, and smoking in particular has a synergistic effect with GORD. So in terms of the clinical features, Barrett's itself doesn't cause any symptoms. It's usually identified on endoscopy for investigation of reflux type symptoms and reflux symptoms essentially. So that's how it would be picked up. On endoscopy, you suspect it when the squamocolumnar junction, or Z-line as it's commonly referred to, is located at least a centimetre more proximal to where it would typically be at the GOJ, and you can appreciate that on this image here. So this is basically an endoscopic view of the esophagus looking towards the GOJ, and you can see basically these tongues of kind of salmon-coloured mucosa, and that's the Barrett's there. Whilst that's a pretty classic appearance, the diagnosis of Barrett's is confirmed with histology and biopsies. So if something like this is seen, at least 4 biopsies should be performed for every 2 centimetre segment around the quadrants of the esophagus. And not only does that confirm the diagnosis of Barrett's, but it also identifies the degree of dysplasia, which is important from a management perspective. So this is probably a bit of a busy flow chart outlining management. But I think the key thing to hone in on here is that management is really contingent on the presence of dysplasia. So if there's no dysplasia, then patients should typically be counseled to remain on the PPI and cease smoking and alcohol intake, and they should get a surveillance somewhere in the territory of 3 to 5 years down the line. Likewise, if the histological findings are indefinite, then their medical therapy should be optimised, and they should get a pretty close interval repeat endoscopy with rebiopsying in 2 to 6 months, because there's obviously a chance that they could be kind of upscaled in their disease in a way. EAC just stands for esophageal adenocarcinoma, and obviously if that's identified in the biopsy, then they're managed as per the cancer pathway. If there's confirmed dysplasia, then it's pretty important. So I mentioned on diagnosis, kind of 2 centimetre segment biopsies, but if you confirm dysplasia, that they should have 4 quadrant biopsies with much closer segment intervals, just to make sure that you're not missing out on higher areas of dysplasia or cancer. And if there is dysplasia, then they should be referred to endoscopic eradication. An example of that is radiofrequency ablation for the lining of the distal esophagus. So I wouldn't get too caught up in the nitty-gritty of this algorithm, but rather appreciate that Barrett's patients are typically going to fall down a pathway of some form of surveillance, and your management's contingent on just the presence of dysplasia and the degree of that dysplasia. If there is dysplasia, they're going to need some form of endoscopic eradication. If you pick up cancer, then obviously it's managed as cancer. Okay, so moving on to peptic ulcer disease. So it's obviously a defect in the gastric or duodenal mucosa that extends through the muscularis mucosa into deeper layers of the GI wall. The classic 2 kind of associations and major contributing factors are H. pylori infection and non-steroidal use. As a background, smoking and alcohol increase the risk, as does corticosteroid use. So obviously, patients on high-dose steroids such as prednisolone should be covered with a PPI. Overall, the rates of peptic ulcer disease have been declining, and that seems to parallel with a decline in the rates of H. pylori infection kind of in developed countries. So in terms of the clinical presentation, a majority of these patients are asymptomatic, sorry. If they do develop symptoms, then these tend to be fairly non-specific, might include like vague epigastric discomfort, bloating, nausea, early satiety. And their symptoms are going to be a lot more overt and obvious if obviously they develop a complication. So bleeding, as you recall, particularly with ulcers in the first part of the duodenum, that erodes through to the GDA, they can present with quite significant upper GI bleed. Gastric outlet obstruction is a possibility, particularly if they've got obviously a more distal ulcer that's large or is causing quite significant scar tissue formation. Penetration fistula are possible complications that can penetrate obviously through to the pancreas that lies just behind the stomach. And similarly, you can get gastrocolic and duodenocolic fistulas through the duodenum, through the large bowel. And perforation is, one of the more classic presentations you're going to encounter in MCQs and OSCE situations, and they're obviously going to present peritonitic and septic. More subtle signs, they might present with an anemia. Incidentally, on bloods, they might be iron deficient. Obviously, if they've got an ulcer that's causing a slow oc or bleed that's not clinically evident. In terms of the diagnosis, it's confirmed with endoscopy. Biopsies should also be taken from the entry of the body of the stomach to test for underlying H. pylori infection. If the ulcer has any malignant features, then the ulcer itself should also be biopsied, and some of those features are listed here. So it's quite a protruding ulcerated mass. If there are folds surrounding an ulcerated crater that are quite nodular, club or fused, then that should also be biopsied. That's an image of an ulcer there. You can see that it kind of has a fairly clean base and going towards the distal part of the stomach there. And in terms of management, so obviously if you identify that they have H. pylori infection, they should have eradication. Typical regimen that we use here in SA is the HP7 therapy, which comes in a pack that basically contains either one of esomeprazole or omeprazole, along with amoxicillin and clarithromycin, and that's taken for a week. Obviously address any underlying risk factors, so they should cease any non-steroidal or aspirin if they're on it, should have a PPI. In terms of surveillance endoscopies, the risk of cancer is thought to be quite low with duodenal ulcers, so endoscopy in this setting isn't particularly indicated unless they have persistent symptoms beyond a month of good medical therapy. The risk of cancer is higher with gastric ulcers, so roughly 2 months down the line, and if they've got any suspicious features on their initial endoscopy, if the cause of the initial ulcer is unclear, if it's quite large in size, or if they have persistent symptoms, then they need a scoring endoscopy as well. So coming to, so that's kind of most of the benign conditions that we'll talk about covered. Is that all fairly straightforward and clear, guys? I'm just conscientious of time. I'll try to race through the next few slides fairly quickly. I think you guys will have a copy of these so you can read through it in more detail in your own time. In terms of the first about cancers, so esophageal cancer and gastric cancer, a lot of what I say for the esophagus will overlap with the stomach, particularly when it comes to diagnosis and staging, the general principles of management. So it's fairly straightforward in that sense. And for the esophagus, represents kind of 1.1% of all new cancer diagnoses. This is Australian data. 2.8% of all deaths. The overall 5-year survival is just north of 20%, which is pretty poor, obviously, and that's a reflection of many of these cancers presenting at quite an advanced stage. majority of esophageal cancers from a histological point of view are SCCs or adenocarcinomas. And it's important to be aware of the risk factors for each and how they differ slightly. So with SCCs, that's classically with the risk factors of corrosive ingestions, achalasias, and family histories that are positive, and smoking and alcohol. They kind of contribute to both SCCs and adeno-CAs, but more so SCCs. And adenocarcinoma is classically, and that's your association with reflux, underlying Barrett's, obesity, H. pylori infection. And so I'd be, that's pretty fair game for an MCQ type question to be aware of those risk factors and how they differ slightly between the two histo subtypes. In terms of the clinical presentation, dysphagia and weight loss are possibilities, and iron deficiency anemia, obviously if they're slowly bleeding from a cancer, might also be picked up incidentally on an endoscopy that the patient's having for Barrett's or for some other indication, such as reflux type symptoms. Might also be picked up on imaging done for some other reason, and you might see a bit of a non-specific thickening of the distal esophagus or the esophagus, or a more frank and obvious mass. In terms of cancer, and you can apply this really to a majority of cancers, especially in the GI tract, think about it in your mind as diagnosis, staging, and then that guides management. Diagnosis is confirmed with an endoscopy. A biopsy of the mass is obviously done, not just because obviously that confirms things from a histological point of view, but if a patient is going to have chemotherapy or radiotherapy or any oncological treatment, that can't really be given without a clear-cut histological diagnosis. It's also really relevant from the point of view of new and evolving immunotherapies. So when they perform these biopsies, they'll do various ancillary studies and immunohistochemistry stains to get an idea of any possible immunomodulators that might be able to target these cancers. Staging, if you guys want to have a go at rattling off some of the common investigations that you might order for a patient with esophageal cancer.
Would you do like a CT chest, CT abdo, possibly a PET scan?
Yeah, absolutely. So CT chest, abdo, pelvis, and obviously you're thinking about looking at how extensive the primary lesion is, but you think about where this kind of cancer is going to metastasize. It's going to be common places like lungs and liver. So CT is obviously very useful there. You mentioned PET, that's pretty good as well. Slightly more controversial, but where PET is quite strong is for picking up occult PET avid disease that's not immediately obvious on the CT scan, and that might obviously influence the way a patient is managed. Can you guys think of any other investigations that you might do from a staging point of view?
Do you do an explorative laparoscopy or something? I kept reading that.
Yeah, that's another area that's a bit more controversial. Some centres will do a staging laparoscopy, and that's basically to look at any peritoneal diseases, sometimes to do washings for more distal esophageal and predominantly gastric cancers. But I'd say that that's probably more in a grey zone. I wouldn't give that as a top of the list answer, just because it's controversial and possible place for it's the potentially resectable disease, as I said, and if they want to make sure that there's no peritoneal disease before proceeding with a potentially curative operation. So possible one, but I wouldn't have it at the top of the list. And you might have also read about things like endoscopic ultrasounds done together with an endoscopy, they can give a pretty good idea about the T staging of the cancer, so how the extent that it involves the esophageal wall. And you can also get a bit of a view of any nearby lymph nodes, bit of a limited view of the liver for any metastases. And the other advantage with an AUSS is that if there are any suspicious lymph nodes, you can potentially do an AUSS guided biopsy of those nodes. That's another one that you probably read a reasonable amount about in textbooks and up to date, but it isn't super common in hospitals around the place in SA. So yeah, this pretty much covers everything that we chatted about. And I think a good way of organising it in your mind is to think about the staging as local regional, and then investigations looking for distant metastases. I haven't included it on these slides, but what might you guys be interested in doing from the point of view of blood tests, just simple blood tests? So rattle off some answers and the reason why you want those tests.
So like a CBE to check for anemia.
Perfect. Yeah, absolutely. Anything else?
Is there a tumour marker for esophageal cancer?
Yeah, there are some pretty non-specific tumour markers. I don't recall the exact ones off the top of my head. Probably would include things like 15.3 and cancer antigen 15.3 and so on. They're not super useful in that they're fairly non-specific, but where they might have some merit is if they're quite elevated initially in a patient, and then if you treat them and that level more or less becomes zero, it's useful from the point of view of disease recurrence, because if it were to be elevated, become normal, and then years down the track they have some suspicious symptoms and it's elevated again, then you might be concerned for disease recurrence. But as you guys would have come across with a lot of cancers, a lot of those tumour markers are fairly non-specific. So it has a place, but not crucial. Think about some more kind of common, straightforward tests.
LFTs.
Sorry, I thought you spoke at the same time. What was that?
I think we both said LFTs.
Yeah, perfect. And why LFTs?
Because there's a common site for metastasis.
Yeah, perfect. For someone to have LFT derangers from METs, it has to generally be pretty high burden disease in the liver, or METs in the right place to cause biliary obstruction. But yeah, it certainly could be elevated in some cases of metastatic disease. But probably the other useful reason would be if you're thinking ahead towards management and giving someone chemotherapy. Some chemotherapy agents can be hepatotoxic, so you want to make sure that they have normal liver function to start things off with. And along a similar note, what's another organ's function that you might be keen on knowing?
Kidneys, so EUC.
Yeah, brilliant. Yeah, so EUC and creatinine. And along similar lines, if someone's potentially heading towards chemotherapy or a big operation for that matter, can you guys think of any other tests that might be useful?
Before surgery, do you like to get coagulation studies or not always?
Yeah. In a big operation like this, I'd be pretty keen on having coags and obviously a group and hold. Think about the fitness of the patient, and think about maybe some other organs that could be negatively impacted by things like chemo.
Is it like something fertility related or?
What's that, sorry?
Do you mean something like fertility related?
Not necessarily. I was kind of thinking along the lines of things like echocardiograms for the heart. So some chemo agents can be cardiotoxic. Similarly, in certain patients, you might want to get lung function tests as well, particularly if they've got background COPD or emphysema. So things like that, just to get an overall idea of their fitness for surgery and chemo. Okay, so I've included here just for your reading the T&M staging. To be honest, it'd be pretty cool, I reckon, to grill you guys on this in an exam setting. But I guess just have an appreciation on that some of the main layers of the esophagus and the implications that has for T-up staging. Appreciate that overall staging takes into account lymph node metastases, and similarly, the greater the number of lymph nodes involved, the higher the end stage. And obviously, as with any cancer in TNM, accounts for distal metastases. So from this, you derive the patient's stage, and that then lends to management. Again, a bit of a busy algorithm here that kind of contains more specialist knowledge. But what I take away from it, guys, is just to have an overall appreciation of the general groups that patients fall into. So if you've got a patient that's not fit for surgery or chemotherapy, they're very frail, very unwell, then palliation is going to be the mainstay there. If they've got metastatic disease, but they're reasonable candidates from the point of view of comorbidities, then chemotherapy or radiotherapy might be an option, just to buy them a bit more time to control their burden of disease and for symptom control. So an example here might be dysphagia or bleeding, which can be targeted by radiotherapy. So the radiotherapy can kind of be used with palliative intent in those settings. If they've got limited disease, and obviously these kinds of patients are going to be discussed extensively in an MDT meeting with surgeons, oncologists, radiologists, radiation oncologists, but just appreciate in the right subset of patients, and they'll be offered a resection, and they're likely going to receive some form of adjuvant systemic therapy. So that's chemotherapy that follows their operation. In more locally advanced disease, another approach that's used is neoadjuvant chemotherapy. So that's chemotherapy delivered before surgery, and the aim there is to hopefully downstage disease, shrink the tumor to some extent, and increase the chances of a good outcome from surgery. So I just kind of have these broad principles in your mind in terms of how you manage these patients, and a lot of these overlap with gastric cancer management. Obviously, another important thing to think about in these patients is nutrition, especially if they've got dysphagia, then they become quite malnourished. So options here might include endoscopically inserting a net tube that passes the point of obstruction to give the patient net feeds. Alternatively, sometimes a palliative kind of bypass operation might be done, or the patient might be given a feeding jejunostomy to facilitate nutrition. So that's another key issue in these patients. So coming to gastric cancer now, broadly similar figures, 1.6% of all new cancer diagnoses, 2.3% of all deaths. And again, a pretty poor 5-year survival, and that's again a reflection of its tendency to present pretty late stage. And kind of you recall from CBL days, it's classically divided into two histological subtypes: your intestinal type, and then your diffuse type, and that'll give us a classic clinical appearance that you've seen in a moment. And the main risk factors are H. pylori infection, family history, poor diet, smoking, obesity, and then you've got some other more uncommon ones like EBV infection, but a lot of overlap again with esophageal cancer. And in terms of clinical presentation, weight loss is pretty common. Might have abdominal pain, dysphagia might be present, particularly if it's a proximal gastric cancer or kind of right near the esophagogastric junction, or they might get a pseudo achalasia if it's invading to Auerbach's plexus and kind of affecting motility near the OGJ. Nausea and early satiety are pretty common, and that's more prominent with that diffuse histological type that I mentioned, where you get kind of a description of a linitis plastica or a kind of a plastic flask appearance to the stomach, where it's very rigid and non-distensible. Vomiting is another possibility, and that's particularly the case if they have a distal tumour causing an outlet obstruction. And again, occult GI bleeding can lead to an iron deficiency anemia. Exam findings, it's not particularly common in clinical practice that you see some of these classic, Burkhoff's node or Sister Mary Joseph's nodule if they have lymphatic metastases. And if they have peritoneal spread, they might have quite a prominent pelvic mass. So you have mets to the ovarian lining, that's classically called a Krukenberg tumour. If they have peritoneal spread or pretty high burden of liver metastases, then they can obviously get a malignant ascites, and if the burden in the liver is high enough, then possibly even jaundice. I've thrown this in there just because it's kind of a classic kind of spot MCQ type question. Does anyone know what this is?
I remember I saw it in reading. It's like keratosis, something. I can't exactly remember.
Yeah. So basically, you get kind of rapidly progressing seborrheic keratosis, and it's kind of called a sign of lesser Trelay, but it's kind of this pretty niche, rare sign where they get the eruption of all these keratoses, and one of the cancers that it's associated with is gastric cancer. I purely just threw this in there because it's kind of a classic MCQ question that you can get. All right, continuing on with the clinical presentations, might be picked up on CT in the form of a mass or just gastric thickening. Similarly, diagnosis might be heralded if they have overt metastatic disease in the liver. A barium swallow is particularly useful. You might see a filling defect, and if linitis plastica and it's the subtype that they have, then the stomach will look pretty thickened and essentially like a flask. And again, this is regurgitating a lot of the stuff from esophageal cancer, but your staging investigations are fairly similar to before. Again, endoscopic ultrasound is not super commonly done in Australia. A note for PET here, again, the reason you do it is to pick up on occult metastatic disease. But remember that with gastric cancers, they don't tend to be quite as PET avid as esophageal cancer, so you might not necessarily pick them up. And again, blood test wise, similar blood tests to what we mentioned before, and the reasons you perform them. And I'll just throw this up there for just your general reading, but again, contingent on the involvement of the layers of the stomach, nearby visceral organ involvement, and the number of metastases. And similar principles that if they've got early enough stage disease, and they'll proceed to upfront surgery. A lot of the main stages 2, 3, and 4 disease that are deemed to be resectable is neoadjuvant chemotherapy. A lot of studies have been done in this area, and kind of the classic regimen is the FLOT regimen. So they'll get chemo, they'll be staged, they'll get chemo, they'll typically get restaged to see what their response is like to that chemo. If they're a candidate, they'll proceed with surgery, and then following that, they'll get further chemotherapy. So it's kind of like a sandwich approach to management. And again, if it's stage 4 unresectable disease, or if they're a candidate that's not fit for surgery or chemotherapy, then treatment is palliative. If they're fit enough for chemo or radiotherapy, then they might be given just to control disease burden and any troublesome symptoms like bleeding. I've included obesity in here. I was asked to kind of talk to obesity a bit. I'm going to race through fairly quickly. A lot of this you can read in your own time. Obviously, obesity has a lot of metabolic implications, predominantly from a cardiovascular point of view, a lot of complications. So obviously great interest in managing it. Turning straight to surgery, it's quite attractive because you see a pretty quick and sustained improvement in comorbidities like type 2 diabetes, hypertension, and basically metabolic conditions, and that all contributes to a reduction in overall cardiovascular disease risk. And lowers the risk of obesity-related cancer through weight loss. Obviously, they also get improvement in sleep disorders and functional improvement just from carrying less weight. And the classic indications for surgery are a BMI of 40 plus. So this is the kind of stuff that I'd memorize for MCQs. So 40 plus with or without comorbidities, they're a potential candidate. 35 to just under 40 if they also have an associated comorbidity related to that obesity, and that stretches out to 30 to 34.9 if they've got quite difficult to control diabetes or a metabolic syndrome associated with their obesity. That's classically the answer that you're given in an MCQ type question. But I put this slide in here just to make you guys aware that different societies, and particularly some of these more recent 2022 guidelines, are a bit more lenient with the population of patients that will be offered bariatric surgery, and that's primarily just because of all the strong data that's coming out that's showing the significant metabolic advantages to weight loss surgery. And so you can see here that basically those set points have just been reduced. And this is particularly, as I said, for patients with metabolic complications like diabetes and metabolic syndrome. Contraindications to surgery, I'd be aware of these as well for an MCQ. So major depression or psychosis, underlying eating disorders, drug or alcohol abuse, any significant cardiopulmonary disease that's going to put them at a very high anesthetic risk, obviously severe coagulopathy. And the last point is also pretty important. You might not appreciate, guys, that the process for bariatric surgery is a very long, arduous, and there's a lot to it. Not only is it's not as simple as a patient being seen by a bariatric surgeon, but they need a workup that includes a review by a dietitian. They need to be counselled on dietary and lifestyle changes. They need to show an ability to commit to those changes and maintain those changes. They need to be seen by a physio for an exercise regimen. They should also be seen by a psychiatrist to rule out any underlying psychiatric disorders. They preoperatively need an endoscopy to make sure you're not missing anything, and nutritional issues are also very common. So obviously these patients have very prominent caloric excess, but they tend to be very protein deplete and micronutrient deplete. So that needs to be supplemented pre and post-operatively. Might skip through this slide fairly quickly, and we're kind of coming to the close of the session, and I want to run through the SOSCI station with you guys, but just have an overview understanding of the possible weight loss operations and the predominant mechanism that they work through. So in terms of restrictive operations, your classic example here is sleeve gastrectomy, and that primarily works by reducing the size and capacity of the stomach and thereby limiting intake. Lap bands have really fallen out of favor. You might, from your time in the hospital, come across a number of patients with these, but they're being offered less and less these days. In terms of malabsorptive type procedures, these basically involve some way of reducing the absorptive capacity and availability of small intestine that's available for absorption. And that's either through some form of bypass or diversion. Obviously, with these types of operations, you'd have a high risk of metabolic and vitamin deficiencies as a result. Probably a pretty common example of operations that you guys would have come across is a Roux-en-Y gastric bypass, which is shown in the diagram here. And that involves an element of both restriction and malabsorption. So we'll round off the session by running through an OSCE practice scenario. So I'll get you guys to have a go at taking the history. If someone's particularly keen to do it all, then go ahead. But I'm happy if you guys kind of take turns at asking some historical questions. The scenario basically goes that you're an ED intern. You're reviewing a 60-year-old gentleman who's presented with significant nausea and vomiting. And you've got roughly 6 minutes to take a history. Then I want you to chat to me about the examinations that you'd like to do, your top differentials, and then give a brief outline of the investigations that you'd want to do in your initial management. So anyone particularly keen to start us off with the history?
You can ask the duration and how much they vomited and how many times.
Yeah, how many times? Okay, so look, I've noticed that the nausea has gradually been progressing over a couple of weeks. At first, I thought it was related to indigestion, but to be honest, for the past 3 days, I just have not been able to keep anything down at all. My symptoms were worse after meals. Now I can't even keep a glass of water down; it just comes straight up.
Yep, and can you describe what's in your vomit?
Yeah, so it's pretty much just gastric content, anything that I tried to eat.
Yep, is there any blood in your vomit?
I'll probably notice a couple of flecks of darker looking stuff occasionally, but I haven't seen any bright blood. To be honest, I thought it was food poisoning, but it just really has not gotten better over 3 or 4 days now, so I thought it'd come in.
Have you noticed any abdominal pain or distension, bloating?
Yeah, I've probably felt a bit more full and bloated for the past couple of weeks. Bit of a niggling discomfort, I'd say, at the top of my abdomen, but no real pain, to be honest.
Have you noticed any blood in your stools?
I've noticed them to be a bit darker than usual from time to time over the past couple of months, but I've never noticed any bright blood.
Do you take a lot of painkillers?
No, not really, just Panadol from time to time.
Have you been traveling recently?
No.
Any changes to your bowel habits?
What do you mean?
Any constipation or diarrhea, for example?
No, I'm fairly regular. I haven't really noticed any changes there apart from what I mentioned before about it being a bit darker from time to time.
Okay. And what was the last time you opened your bowels?
Yesterday.
And that was normal?
Yeah, it was normal.
Okay.
Are you
Have
still
you lost any weight?
Yeah, I mean, I haven't really been keeping an eye on the scales, but I would say my clothes have been getting a lot looser over the past couple of months. Yeah.
Are you still passing wind?
Yeah.
Have you been more fatigued than usual?
Yeah, definitely. So I work in construction, and yeah, it's past few weeks it's been really difficult to get through a full day's work.
Are you waking up feeling tired, or is it fatigue that comes on after exertion?
Yeah, it tends to be more later in the day that I've noticed it.
Do you take your
Sorry, you dropped out there.
Do you have any
Sorry,
different
just say that again. What was that?
any
Sorry, I was just asking, do you take any medications?
Yes, I've got high blood pressure. I'm on a blood pressure tablet for that. I had a heart attack a couple of years ago and a stent put in one of my heart vessels, and I'm on aspirin for that.
Have you had difficulty swallowing in the past,
No, not really.
or any reflux?
Oh yes, I forgot to mention I've also got reflux, and I'm on a PPI for that.
Do you drink any alcohol?
Yeah, probably two standard drinks a day, and smoking 20 cigarettes a day since age 15.
Do you have a binge drink?
No, not recently. Cool. So I think you guys have covered a lot of the pertinent questions that I had listed down here. And I could see that you had certain differentials in mind as you were asking a lot of those history and comparative questions. What else is going to be pertinent? And then obviously I'm leaning towards this being a surgical related station, but what else would you want to know about in the past history?
Allergies, if they're fasted, past surgical history.
Yeah. So all that basic stuff is important to cover in an OSCE. So allergies, medications that we touched on, specifically asking about blood thinners. In this case, you're worried about something GI going on. So ask if they've had an endoscopy before, a colonoscopy before, have they had any GI operations? In this case, I've never had an endoscopy or a colonoscopy, and had an open appendicectomy in 1990. Cool. So we might move on with that, guys. So here is a lot of the information that you already covered. What might you want to assess on examination?
The vitals and hydration status.
Yeah, excellent. So blood pressure is 110/80, heart rate is 110, and the patient looks pretty pale and dehydrated, and they're dry retching in front of you.
Should probably give them some IV fluids then.
Yeah, sounds sensible. What else might you want to do from an examination point of view?
Is it called a succussion splash or something like that?
Yeah.
Succussion?
So yes, I guess the picture that I'm painting in this history is possibly suggestive of a gastric outlet obstruction, so they can get a succussion splash. And do you want to describe what that is?
Well, I was going to ask you because I swear I can hear it on myself when I do it.
Yeah, so basically you auscultate over the stomach area, and you hear a splash with moving the stomach side to side. I mean, it's one, I think I've included it on these slides purely because it comes up in MCQs and OSCEs and textbooks, but it's pretty non-specific. But yeah, it's something that's classically associated with a gastric outlet obstruction. What else might you want to do from an examination point of view?
An acute abdomen.
Yeah, an acute abdomen would be sensible. So looking for areas of tenderness. And I'll show you guys the findings there. And you also get a pretty quick x-ray done. There's an impression of a large dilated stomach, no appreciable small bowel or large bowel loops that are dilated. So taking into account all the history and examination findings, what's at the top of your list?
Gastric outlet obstruction, probably due to a malignancy.
Yeah, some kind of malignant process, perfect. And when you were just beginning to get the history, what differentials do you have just in general for nausea and vomiting? Because remember, you have at the back of your mind that the gastric outlet obstruction question has come up before, but remember you have to approach these kinds of things with a broad mind. So nausea and vomiting, what are the possibilities?
A gastric cancer.
Yeah, so gastric cancer, again, as we touched on, if they've got an outlet obstruction or a proximal esophageal distal esophageal involvement, they might have dysphagia and associated regurgitation with that. But beyond cancer, what else could they have?
Gastroenteritis.
Yeah, gastroenteritis, perfect. What else?
Like a small bowel obstruction from some other cause.
Excellent. A small bowel obstruction. So gastroenteritis, someone asked about recent travel, any recent, asking about any recent takeaway or any sick content. Contacts is going to tell the examiner that you're thinking about that differential. Small bowel obstruction, so what are the key risk factors for that? What can't you miss from the history?
Past surgical history.
Absolutely. So remember, majority of small bowel obstructions are adhesional in etiology, and in the absence of that, your management's quite different. So you have to know about the past surgical history. Excellent. Anything else that you guys can think of?
Prior to hearing about like pain, I forgot how old he is, but like an appendicitis possibly.
Yeah, absolutely. Any acute intra-abdominal kind of pathology like appendicitis or cholecystitis could cause nausea and vomiting.
Or diverticulitis.
Yeah, if they have an associated ileus with the diverticulitis, they might have some nausea and vomiting. Remember, guys, that nausea and vomiting are pretty non-specific symptoms with a broad range of possibilities. And this is exactly why you guys were as comprehensive as you were with your history. You're asking about red flag symptoms, you're asking about upper GI symptoms, you're asking about lower GI symptoms, bowel changes. So that's all relevant. Any other differentials that we've missed?
DKA.
DK, yeah, that's a good one not to miss. Yeah, so type 1 diabetic, a young patient, can kind of masquerade as an acute abdomen. So yeah, that's a good one that you don't want to miss.
Thinking like other symptoms like a myocardial infarction.
Yeah. So particularly if they've got either chest pain or epigastric discomfort, then an MI, yeah. And this guy has all those risk factors as well, so that's very pertinent. Yeah.
I guess other conditions that can bring about acute, like extreme pain, like maybe testicular torsion or ectopic pregnancy, things like that.
Yeah, Yeah, potentially in the right person. Renal stones, renal colic, that can cause really severe excruciating pain and often has nausea and vomiting along with it. Someone asked about alcohol intake and recent alcohol binges. What differential might that skew you towards?
Pancreatitis.
Yeah, perfect. Brilliant. Cool. So in this case, I was obviously painting a bit of a picture of gastric outlet obstruction. So marked nausea and vomiting, very significant postprandial symptoms, poor tolerance of any oral intake. The X-ray findings are all pretty consistent with that. In terms of the causes, it's good to bundle them up as benign and malignant. And then furthermore, under benign, you can class it as inflammatory. So if they have peptic ulcer disease, quite a prominent stricturing and scarring type reaction, they could get an outlet obstruction. Pancreatitis in itself can cause nausea and vomiting, but also if there's quite significant edema at the head of the pancreas, that can kind of intrinsically compress the distal stomach, or rather the first part of the duodenum. And more rarely, you're going to get things like duodenal Crohn's disease that cause stricturing. That's not particularly common. Post any recent operation, but I mean, it's going to be pretty clear cut if they're having a complication related to a surgery. That'll be evident in the history. Pretty uncommonly these days, intragastric balloons are sometimes used as a weight loss measure to increase satiety. So if that kind of migrates distally, then that can cause outlet obstruction. And then you've got other pretty rare conditions that Bouvret syndrome is when you have a gallstone that kind of impacts the distal duodenum. Gastric dissolves kind of the hair and other foreign matter kind of accumulating in the ball. But again, that's pretty rare stuff that you're not going to really focus on the top inflammatory conditions here. And then on the other side, malignant conditions, and we're really thinking malignant from this history because of those concerning constitutionals I gave you. So the distal gastric cancer, similarly pancreatic cancer that's locally invasive could cause it, gastric lymphoma, and then really any malignancy of the duodenum, gallbladder, or distal bile ducts could cause it. So in terms of some of the initial investigations, an ECG, so someone mentioned obviously MI being a differential. Why else might you want to do an ECG in this patient?
Rule out an MI.
Yeah. So rule out an MI. Why else?
Vomiting can cause like hypokalemia, which can cause ECG changes.
Excellent. Yeah. And what might you expect to see in a patient who's quite significantly dehydrated?
They'll be hypokalemic.
Yeah. So they might have, electrolyte related ECG changes. They might have sinus tachycardia just because they're so fluid deplete. Blood tests. What would you guys want to order?
CBE and EUC.
Perfect. So why CBE?
To check for any anemia, particularly if you have a normocytic anemia, maybe suggestive of an acute blood loss.
Yeah, perfect. Looking for anemia. Excellent. What else on blood tests?
And the EUC, particularly urea to creatinine ratio, may be suggestive of a lower GI bleed.
Yeah, so
as well as any electrolyte derangements.
Yeah, perfect. Electrolyte derangements. If they are bleeding, then they might have so I think you mean there, if their urea is elevated, they might point towards an upper GI bleed.
Yeah.
And again, we're thinking about liver function, renal function, and what's the classic electrolyte derangement you might expect in this patient.
I
Hypokalemia.
think hyponatremia as well.
Yep, might get hyponatremia. Yeah.
They could have like a raised creatinine if they've got an AKI from hypovolemia.
Yeah, absolutely. If they're dehydrated, they might have an AKI that you need to manage. And along with the electrolyte range, and obviously they're losing a lot of acid from their stomachs. Pretty classically, they'll get that kind of hypochloremic, hyperkalemic metabolic alkalosis, and that might be evident on the bloods. And imaging-wise, I already gave you guys an X-ray, but what imaging might you order?
Chest X-ray.
Yeah, chest X-ray. Why chest X-ray?
Is there any perforation? You can see air under the diaphragm.
Yeah. It's a pretty useful test if someone's particularly presenting with an acute abdomen, a pretty quick one. I've already obviously given you the abdominal X-ray, but any other imaging that you guys can think of?
CT abdomen.
CT abdomen, yeah, excellent. And what's your initial management going to look like?
Nasal gastric tube insertion, fluid resus.
Perfect, spot on. So pretty aggressive fluid resuscitation is going to be quite deplete. What would your choice of fluid be? What's a pretty good fluid to pick in this setting?
Hartmann's.
Especially if it's got a hyperkalemic metabolic alkalosis.
Hartmann's solution and potentially potassium replacement.
Yeah, excellent. So something like Hartmann's with potassium replacement. If he's got a metabolic alkalosis and he's got quite significant acid losses, and even initially something like simple normal saline would be pretty useful with potassium on top of that. And you mentioned a nasogastric tube. Excellent. So that's useful and obviously to decompress and improve symptoms. What's another benefit of a nasogastric tube?
It can suck up the acid.
Yeah, you can. What is someone at risk of if they're continuously profusely vomiting? Exactly, they can aspirate, and that's a big problem, a common problem, and a significant problem from a morbidity and even a mortality point of view. People can die from aspiration pneumonia, so you're addressing both of those things with a nasogastric tube. Anything else? Think simple stuff. This guy looks pretty uncomfortable. What else are you going to give him?
Analgesia.
Yeah, excellent.
Maybe antiemetics.
And antiemetics. Yeah, excellent. Cool. And then, so your CTs identifies kind of distal pyloric thickening of the pylorus. It looks like there's a mass there. The proximal stomach is quite significantly distended with it looks like a lot of food content left in there. From here on in, you're going to refer to the GI surgeons and take it from there. But this is just a snapshot to focus on the initial management, and then, as we touched on earlier, the principles of gastric cancer management will apply. So they'll eventually get an endoscopy pretty shortly after their admission to confirm the diagnosis. They'll be staged up, and then management will be dictated from there. Cool. Now, I think, if I'm not wrong, that's everything. Sorry we ran a bit over time, guys, but I hope that was reasonably helpful for you leading into your OSCEs and your MCQs, and serves as a bit of a good foundation for you to do a bit more reading around those topics. I think as a bit of feedback, it's always a bit hard with an OSCE station when you're kind of tag teaming it over Zoom, but try to maintain the structure you would have learned from third year in your mind. So exploring your history of presenting complaint, being comprehensive with your past medical history, your past surgical history. And a good way of doing your symptoms is bundling them up into kind of red flag symptoms and cluster them according to your differentials. You guys were clearly thinking about gastric outlet obstruction and cancer, so cover all your constitutionals in one go. If you're thinking It could be pancreatitis. Cover your risk factors and pertinent questions for that in one go. So if you kind of approach it in that way, you're less likely to miss out big stuff from your history. Anything else, guys? Any burning questions, or guys are pretty keen to let you head off to enjoy the rest of your Thursday evening?
I had a question.
Yeah, go for it.
I think I'm a bit confused on when to order like what imaging for acute abdo, like ultrasound, CT, abdo pelvis, and chest X-ray. Like, do we just say all of them?
Yeah. So I would kind of tailor it to the differentials that you're thinking about. In general, in any acute abdomen, an X-ray is pretty quick to get, so it's a good one to do in most cases. I particularly like X-rays if you can suspecting an obstruction, because it's going to give you a quick snapshot view of the abdomen. It's not going to give you all the answers that you need, but you're going to see dilated loops of small bowel and large bowel. So it's great for obstruction in X-ray, and also an erect chest X-ray is useful if they're in quite significant pain, because you'll see obviously pneumoperitoneum. Nothing that you can really hang your hat on, nowhere near as reliable as the CT, but it's just a good answer to give off the cuff for an auscultation. Next up is ultrasound. Ultrasound is excellent for biliary pathology. So if you're suspecting cholecystitis, then it's a gold standard for diagnosis of that. It's good for other biliary pathology, like you can check for bile duct dilatation. It's not good for seeing. Often you won't be able to see choledocholithiasis just because of the body habitus of the patient or a loop of bowel being in the way, but you can get a clue if the bile ducts are dilated. So in that setting, it's very useful. So biliary pathology. And then the other place where ultrasound is very strong is in young females with lower abdominal pain. So you're going to get a pelvic and transvaginal ultrasound. That's pertinent from, ovarian pathology, ectopics, and nowhere near as sensitive as the CT, but in some cases you can pick up on something like an appendicitis from an ultrasound as well. So that's another use for it there. So biliary, young females or lower abdominal pain, ultrasound is excellent for. And then that leaves CT. So CT, highly sensitive and specific for most diagnoses. And obviously you're mindful of the fact that it carries a risk of ionizing radiation exposure. So in patients who are very unwell and septic, who aren't in need of an immediate trip to theatre, I generally advocate for a CT in that case to give you a diagnosis and help you plan for what to expect in theatre. And then in general, older patients, you can be fairly liberal with a CT scan to get you a diagnosis. So that's kind of how I think about, I don't know if that helps, how I think about imaging in my